Prolonged comas have long captivated the medical community and the public. Cases like Elaine Esposito and Obara highlight the body's capacity to sustain life. These comas challenge our definitions of life and consciousness. They push the boundaries of medical ethics and palliative care. These cases continue to inform patient care and inspire research. It is crucial to understand that coma is fundamentally different from sleep, though both involve a state of unconsciousness. Sleep is a natural, reversible state of reduced responsiveness, essential for bodily and mental restoration. In contrast, a coma is a profound state of unarousable unconsciousness. It results from severe dysfunction of the brainstem's reticular activating system or widespread damage to both cerebral hemispheres. Patients in a coma do not exhibit sleep-wake cycles and cannot be roused by any external stimuli. Historically, methods for treating comatose patients were often rudimentary and sometimes misguided, reflecting a limited understanding of brain function. Some outdated practices involved aggressive or even painful stimulation in an attempt to awaken the patient. Modern approaches have evolved significantly, moving towards more nuanced and evidence-based care. The focus is now on identifying and treating the underlying cause of the coma, providing comprehensive supportive care to prevent secondary complications. There is a greater appreciation for the heterogeneity of coma states and the need for individualized treatment plans. This shift reflects a deeper understanding of neurobiology and a more compassionate, patient-centered approach to care for individuals in these vulnerable states. Acknowledging the complexity of their condition and the limits of aggressive intervention is crucial. The term coma describes a state of profound unresponsiveness where the individual cannot be awakened, shows no purposeful responses to stimuli, and lacks sleep-wake cycles. Clinically, a patient in a coma will have their eyes closed and will not demonstrate any awareness of themselves or their environment. The Glasgow Coma Scale, or GCS, is a common tool used to assess the level of consciousness by evaluating eye-opening, verbal response, and motor response. From a coma, patients may recover, progress to brain death, or transition into other states of impaired consciousness. One such state is the vegetative state, now often referred to as unresponsive wakefulness syndrome, or UWS. Another distinct state is the minimally conscious state, or MCS, where patients show clear but inconsistent signs of awareness. Differentiating MCS from UWS is crucial for prognosis and treatment decisions. Advanced neuroimaging techniques are sometimes used to help detect subtle signs of awareness that may not be apparent through bedside clinical examination alone. It is also important to distinguish coma and related states from conditions like locked-in syndrome and catatonia. Accurate diagnosis based on thorough neurological and psychiatric evaluation is essential to ensure appropriate management. A medically induced coma is a temporary state of deep unconsciousness brought on by controlled doses of anesthetic drugs. It is intentionally created by doctors to protect the brain by reducing its metabolic activity and oxygen demand. This helps lower intracranial pressure and allows the brain time to heal. Situations warranting a medically induced coma are always severe and life-threatening. Despite risks, it can significantly improve the chances of a favorable outcome. Section 5. The body's standstill. Physical complications of extended coma. Prolonged immobility, a hallmark of the comatose state, inevitably leads to a host of physical complications, significantly impacting the patient's overall health and potential for recovery. One of the most common issues is muscle atrophy. Without regular movement and weight-bearing, muscles begin to waste away, losing mass and strength. Bed sores, also known as pressure ulcers, are another serious complication. Constant pressure on an area of skin, especially over bony prominences, restricts blood flow to the tissue. Respiratory complications are also a significant concern for patients in a prolonged coma. Immobility and reliance on mechanical ventilation increase the risk of pneumonia. Prolonged immobility can lead to joint contractures where joints become stiff and fixed in one position. Deep vein thrombosis, the formation of blood clots in the legs, is another risk due to poor circulation from inactivity. These multifaceted physical challenges underscore the intensive nursing care required for comatose patients. Prevention is key, involving regular repositioning, use of specialized pressure-relieving mattresses, and careful skin hygiene. Section 6. The path to awakening. Recovery. Trajectories and prognostic factors. The journey of recovery from a coma is highly variable and depends on a multitude of factors. The underlying cause of the coma is a primary determinant. For example, comas due to metabolic disturbances or drug overdose often have a better prognosis for full recovery. The duration of the coma itself is also critical. Generally, the longer a patient remains in a coma, the lower the chances of a good functional recovery. The depth of the coma, as assessed by tools like the Glasgow Coma Scale, also provides prognostic information. Age and pre-existing health conditions play significant roles as well. The extent and location of brain damage are also crucial. Recovery from coma is not an all-or-nothing event but rather a spectrum. Some patients may make a full neurological recovery, while others may awaken with significant physical, cognitive, or behavioral disabilities. The importance of intensive and specialized rehabilitation cannot be overstated for those who do show signs of recovery. Section 7. The Silent Vigil. The profound emotional impact on families. When a loved one falls into a coma, families are thrust into a world of uncertainty, fear, and profound emotional distress. The initial shock of the event is often overwhelming. Families grapple with the stark reality of seeing a vibrant individual suddenly unresponsive, suspended between life and death. As days turn into weeks and sometimes months or years, the emotional toll on family members evolves but does not necessarily lessen. The strain of maintaining a bedside vigil, juggling work and other family responsibilities, and navigating the complexities of the healthcare system can be exhausting. Hope often fluctuates wildly, leading to feelings of grief, anger, guilt, and depression. Making decisions about ongoing care places an immense ethical and emotional burden on families. Support from healthcare professionals, including clear communication and access to social workers or counselors, is crucial in helping families cope. Recognizing and addressing the profound emotional needs of families is an integral part of providing comprehensive care for patients in a coma. Section 8. Mapping the mind. Current scientific research into coma states. Current scientific research into coma and related disorders of consciousness is intensely focused on improving our understanding of the underlying brain mechanisms. Advanced neuroimaging techniques such as functional magnetic resonance imaging or fMRI and positron emission tomography or PET are playing a pivotal role. These tools allow researchers to observe brain activity in response to various stimuli, even in patients who are behaviorally unresponsive. Electroencephalography or EEG remains a cornerstone in assessing brain function in comatose patients. Modern high-density EEG and sophisticated analytical techniques are providing deeper insights into the brain's electrical activity and communication patterns. Researchers are also investigating the utility of transcranial magnetic stimulation, or TMS, combined with EEG, to directly probe cortical excitability and connectivity. Another key area of research involves the search for reliable biomarkers. Identifying such biomarkers could lead to more objective diagnostic tools and guide personalized treatment strategies. The ultimate goal is to translate these scientific advancements into clinical practice, improving outcomes for patients and providing better support for their families. Section 9. Future Horizons. Speculative thoughts and the quest for deeper understanding. The profound mystery of consciousness, especially when it is impaired or seemingly absent as in a coma, naturally leads to broader, sometimes speculative questions about the nature of subjective experience. Questions about what, if anything, a person in a long-term coma experiences internally are common among families and even clinicians. Is there a dreamlike state, a void, or something entirely different that current science cannot yet grasp? The brain's capacity to generate complex internal worlds, as evidenced by dreams, raises tantalizing albeit unproven thoughts about its potential activities when disconnected from external sensory input. However, it is crucial to differentiate these speculative musings from the evidence-based research that aims to understand and treat disorders of consciousness through rigorous scientific methodology. The ongoing quest to understand coma is fundamentally a quest to understand consciousness itself. Researchers are continually refining models of how consciousness arises from complex brain activity. Future breakthroughs may come from unexpected directions, perhaps through advances in artificial intelligence or new technologies. The hope is that continued research will not only demystify these complex states, but also lead to tangible improvements in care, offering more hope to patients and their families.